Hey everyone, this is Austin Nakatsuka, and I have a case here of a rotisserie lens. So rotisserie meaning it's rotated. The lens is, you can see the optics tilted with the optic edge pretty much facing the cornea. But this is a lens that is an AR40 lens, and it's really interesting how this came to be there because essentially it was not the typical way. I did a AR40 refixation of this lens. It was iris fixated, and I refixated it. And essentially, that I later developed a retinal detachment closely subsequently afterward. And so they did a scleral buckle and put some gas in the eye. Well, what happened is the gas and the bubble got in between in the sulcus space and stuck between the lens and the iris, and basically was pushing that iris forward, and it was pushing the lens back, and it was sticking in there for a long time, long enough so that the lens all of a sudden started to turn and rotate like this. So it wasn't like that on post-op day one. It looked great on post-op day one, but then developed the retinal detachment, had that retinal detachment surgery. The bubble pushed it back, and then it slowly started rotating, and then it became like this. So now I have to fix it. So here I am trying to open up and do a little peritomy over the area of the haptic bulb that has been flanged with the Yamane double flange scleral fixation technique. And here's the thing with these PMMA haptics, like this AR40, is they're really hard to get out sometimes because they fit in there into the sclerotomy so well and scar in there, and they're much smaller than the CT Lucia lens haptic bulbs. So here I am I was struggling to kind of get it out with a 30 gauge needle externally, and that didn't work, and unfortunately he's bleeding. This patient always seems to bleed, and I'm trying to dig it out, and I can't. So I tried to do an ab internal approach and push it out. That's what I was trying to do over there initially, and that didn't work. So now I'm trying to open it up again and see if I can get it again. And oh boy, a lot of bleeding. Yeah, my favorite, lots of bleeding. Okay, so it's not working here. I'm trying to push it out. To the sclerotomy, and that's not working. So then I decided to do something else. And this is a neat little trick there. See that pop? I pulled it internally, ab internally, and see the thing with these haptic bulbs with the PMMA lenses like the AR40 lens or MA60AC lens or ZA9003 lens is that the bulbs are smaller when you flange them, which you have to be careful of because I've had it pop into the eye like that unintentionally, and you don't want that to happen usually. But in this case, it turned out to be better to pull it inside the eye than to push it outside the eye, cut the flange, and then pull it and cut the flange. So with these flanges, it'll pop right straight through the sclerotomy. So if you put too much pressure on them, they'll pop inside, right? And you don't want that in certain cases. But in this case, it was good. So I did that on both sides here, and then cut the lens in half and removed it on each side. So that's a little pro tip. If you're using a PMMA lens and you have to remove a Yamane fixated lens with the flange, if it's a PMMA haptic flange, you can just pull it internally and it should just pop right through. And that's easier than trying to get it from an external approach and pull it out externally like I was trying to do initially. So pro tip right there. Okay, so that came out okay. I didn't drop it, thank goodness. And we sent that lens off to the Liliana and Mammalis Intermountain Lens lab that they have there so they can inspect it and just look at it. And they found some really interesting results there. It looked totally different from the rotisseries that we see with the CT Lucia lenses. It actually looked okay when they looked at it in the lab. There's a little kink in the haptics, but I think that was from actually me pulling it in like that. So don't know how it rotated quite like and I don't think it was exactly like the CT Lucia ones that kind of self-rotate, right, without any issues. But this one was a secondary cause from the air bubble from the retinal detachment surgery. So then I just went right back at it and said, okay, I'm just going to refixate a lens here because I don't feel that was a The rotisserie situation there was one that would happen to a normal lens if it didn't have that bubble there pushing up against it, because that doesn't happen that frequently with the AR40 lenses. I haven't had that happen very frequently at all, and if when I have had it, it's been always because of a secondary cause. Okay, so here I am putting in the leading haptic first. Okay, you see the eye is tilted like this. You don't really want that eye tilted like that, and this is kind of poor technique, and this is me doing this, okay, not a trainee, but anyway, you don't really want that eye tilted, but sometimes you just kind of got to work with what you got. And so this eye is actually blocked. I usually block these, do a retrobulbar block, or other people do subtenons, I know, but I do a retrobulbar block for these. So the eye is essentially frozen by the patient, but then if it goes in the wrong direction, then you got to move the eye, just like I'm doing here. I had to move it to get it where I need it to be. And as you can see here, that tunnel I made was a little on the short side on this trailing haptic side, but I did that on purpose because the leading haptic tunnel I made was a little short too. So I adjusted accordingly to be able to match it. That's what you want to do, is you want to match it. And here I'm struggling a little bit because the angle is kind of funny and the eye's getting a little soft, and you don't really want that usually. But I was just kind of working with the angle. And so we got it through though, and oh, it looks great. Looks great. So, okay, everything turned out okay. It looks great, even though the technique wasn't the best. And yeah, you do have to be careful in those situations. You don't want a choroidal or anything like that to happen. But the outcome looks really good. I'm really happy with that. And the lens is well centered and it's stable. And I'm hoping that a rotisserie situation does not happen, which so far it has not. I've seen him already post-op a couple times, and he has not had a rotisserie situation or a tilted lens situation there. The lens looks great. But anyway, the main point of this procedure or this video is to show you how to deal with a Yamane scleral fixated lens that can be difficult to remove sometimes. If it's a PMMA haptic lens, a lens with haptics that are PMMA, then you can just pull it through the sclerotomies and it will pull through like that. But that's also a warning that can happen intraoperatively when you're doing this, primarily for when you're doing the Yamane scleral fixated technique. So be careful, and it can pop right in. And I've done that before. And this lens ended up looking good. Things look good here. Good outcome at the end. There's a little piece of pigment from the iris. She aspirated. Yeah, it looked good. That wound for the AC maintainer, I almost always will suture because I enlarge it a little bit to fit my AC maintainer, because my AC maintainer is a 21 gauge there. It has those rings, what we call them ribs, that hold it in the cornea. So it's kind of on the large side. We have a smaller one, but it doesn't really hold as well in the paracentesis. So I use this ribbed one, and it's a little larger, but I usually have to enlarge the wound. I always have to suture it closed. And you can suture it with Vicryl as well, but I just use nylon and just cut it out later. And look good at the end. Okay, well, thanks again for watching, and hope you learned something there. And this patient ended up doing really well afterward and looked really good at the end.